Welcome everybody to another of the SJMC Teaching Grand Rounds series. This afternoon we are doing something different. Number one, we've got a completely different team. So instead of cardiologists, you're going to meet the team from SJMC and to demonstrate how lung cancer is a multidisciplinary approach to management. Okay, now before I hand over to the moderator, who is Dr. Martin Mellor, and he will introduce the rest of the team, but briefly, we have Dr. Anand, cardiothoracic surgeon, Dr. Katie Chua, you can raise your hand, yeah, with the respiratory physician, and the other oncologist who will be presenting is Dr. BK Yap. Okay. All right, guys, so I just want to go through the housekeeping slides. So for those of you who have registered for the talk, we've actually given you some preliminary information, and we've said that we are going to allow questions and answers at the end of the session using Slido. So Slido is our interactive platform. So you can join us at Slido.com and you enter the code A651. If you scan this QR code, it will take you to the same site, and A651 will be entered for you automatically. And this is not the QR code to get points, please, so don't try to scan for points now. We will present the QR code for points only at the end of the session. Okay, so I'm going to hand over to Dr. Mellor, because we would like you to use Slido, and we'd like to know something from you viewers before we begin the session. So over to you, Mellor.
Thank you, Alan, for the kind introduction. As introduced, Martin Mellor is my name, and I'll be moderating this session in the afternoon. Also, as indicated, we have got three panelists, presenters, who will be sharing two cases of lung cancer and demonstrating how those are being managed in a multidisciplinary manner. Now, a little bit of information with regards to lung cancer. Now, in the latest cancer registry, Ministry of Health, 2011-2016, lung cancer is the third most common cancer. The first one, of course, everybody knows, is breast cancer, followed by colorectal cancer, then lung cancer. Now, the 5 years relative survival for breast cancer is 66%. For colorectal cancer is 50%. And for lung cancer is a dismal 10%. So you see, there's a lot of work that needs to be done to improve the survival of patients with lung cancer. Now, as I've alluded to, we have got the three panelists. Dr. Yap will present the first case, Dr. Chua the second one. Dr. Anand will input his gray matters into the cases that we are discussing today. So without further ado, I would like to invite...
Before we want to go to the poll,
okay,
so we've got about 3/4 of viewers are GPs.
Okay.
22% are specialists, and others 4%.
Others 4%.
You want to go to the next question, or
I'll do it the next one.
I'll check. So thank you for responding to the poll. We'd like to know who's actually watching our session, and also to get you to use Slido because that will be important for our Q&A later. Next question is, when you hear of lung cancer, what is the first thing which comes to your mind? So this is a free text input, yeah? So put anything which comes to your mind. Just enter some text. Don't be shy. This is anonymous. Anything, pain, death, breathlessness, any word which comes to your mind.
I thought there were some choices, Alan.
No, this is a word cloud.
It's a word cloud. There's free text.
Whatever comes to your mind. Can you guys at least try and see? Well, everybody is very shy.
Maybe it's a little bit complicated to respond to.
Maybe they can't, is it?
Yeah.
I'm sure.
Maybe no matter, Alan, we should proceed.
Okay, never mind. Maybe they're stuck. There is maybe a technical error. This is one more poll. This is an important one. How would you screen for lung cancer? Okay, most of you are GPs. What are your thoughts on screening for lung cancer? Okay. Sorry, there's a typo there. It's CT scan, not CT scab. CT scan, all right.
So the numbers that there are 15 participants, is it, Alan?
Yeah, 15 people have voted. So this is a live poll. So as more and more people, the number will go up, and then the percentage of is real time.
Okay. I think that's nicely responded to these questions, and we will be discussing the role of screening for lung cancer later on, because we've got Anand here to discuss that. Okay, Helen, shall we
go to Dr. Yap's presentation?
Yeah. So the first case will be discussed by Dr. Yap Beng Kiong, consultant in clinical oncology in the SJMC. Beng Kiong?
Okay, thank you, Martin. Welcome, everyone. So we're going to talk about this first case. The outline of my talk is we're going to have this case presentation, and then we're going to have discussion along the way, and then we're going to discuss about the learning points from this case. Okay, so this is a lady, 77 years of age, who presented to SJMC in December 2019. She consulted the gastroenterologist on the 12th of December. So she went for routine blood test, and then she found to have a high CEA, which is a cancer marker of 35. So her past medical history includes non-insulin dependent diabetes mellitus, which is well controlled on glycoside, and she is hypertensive. She's on amlodipine, all very well controlled. She's a never smoker, so she came to the gastroenterologist's office, and then the gastroenterologist actually did a OGDS and colonoscopy 1 year ago, and they were normal. So at this point, maybe we can discuss about screening tools that we have in terms of why the marker is raised. So maybe we can discuss that.
It's very interesting that this patient did not have a lot of symptoms, and we are increasingly seeing patients that come to the clinic with the raised markers with minimal symptoms. What do you think, guys, about the role of cancer markers that you do routinely? And obviously, this patient actually went for a routine clinical examination without any clinical symptoms, and one of the markers tested was CEA that was raised. So, what would be your thoughts about cancer markers to be used on routine screening? And if so, do you just do CEA or do you do other cancer markers? Chua, what do you think?
Right. Now, I believe that, nowadays a lot of patients do come in to see us with this abnormal tumor marker. I believe this test is gaining such a popularity because of easy to access, right? You need a drop of blood. It's relatively cheap, especially compared with CT scan, right? And it doesn't require specific equipment like an X-ray machine, so it's easily doable. Right. Personally, I probably not too supportive of using this test CA as a general screening tool. Yes, on and off there is a kind of cases or patients with positive income where we actually do pick up cancer after pick up an abnormal CA. But obviously, I've seen quite a number as well with an abnormal CA result, and we end up with such an extensive investigation and come to nothing. All right, so I think we ought to be very careful in terms of how we utilize this test at CA level.
What do you think, Anand?
Yeah, Martin, I agree with what Dr. Chua said. I mean, basically, in terms of lung cancer, I think everyone appreciates we don't actually have, at this time point, tumor markers that are specific enough to be used for the purposes of screening or diagnosis. So if we look at CEA, for example, I think we all know the common types of non-small cell, you've got adenocarcinoma and squamous cell, and CEA can be elevated more in the adenocarcinomas, but it can also be elevated in smokers, which is a common risk factor for lung cancer. Now, where we use, I think how we all use tumor markers is more to do with surveillance in terms of monitoring the response to treatment, and certainly to monitor for disease recurrence, either recurrent disease or a new tumor. So that will be useful in a patient who has an elevated baseline tumor marker, in this case here CEA, pre-treatment, and then they go for the definitive treatment, the surgery or chemotherapy or radiotherapy. We would hope and expect there will be a normalization of that tumor marker. But in terms of using it as a screening tool or as a diagnostic tool on its own, it's not specific enough. I mean, we all know majority of patients who have lung cancer will probably have normal tumor markers, so we can't hang our hats on that alone. Yeah.
Your thoughts, begin?
I totally agree. I think we have to remember that not all tumor produce CEA or cancer marker. So this marker is not specific enough, and it's not specific, and it's not sensitive enough to be a general screening tool. So just because not all tumor produce the marker, so as a screening tool, you have to be more sensitive and to be more specific. So I think we do see from time to time that patients presented with marker, and that's how the cancer is diagnosed. I think these are a lucky patient that we detected it. But I think as a general screening tool for the population is not good enough. So I think Dr. Anand alluded earlier that other screening tools like CT scan, chest X-ray, I think they are probably more sensitive than this marker.
We're notwithstanding the fact that this cancer markers do not have the sensitivity and specificity of identifying any particular cancers. It is common practice that GPs does the markers, and actually patients demand cancer markers as well. I think despite all of that, maybe what needs to be done is to actually explain to patients the pros and cons of those marker tests. When they're talking about sensitivity, talking about specificity, talking about the fact that they may be false negative, false positive. If there's a false negative, Dr. Chua alluded to the fact that you might undergo a lot of investigations only to find that there's nothing specifically wrong with yourselves. So those information need to be passed on to patients who want to do the screening test, to do tests using cancer markers. The fact that they are pros and cons, they are negative, false negative, predictive value, they are possibly false negative and false positive to those tests as well. But I think one of the important message, I suppose, is that if the cancer markers are markedly raised, that would certainly suggest something. And another important point to make sure that the patients know is that if the marker tests are normal, it does not mean that there are no cancers.
Martin, if I can just add, I mean, totally agree with what you said. The other thing I just to mention is, so as you say, someone who has confirmed lung cancer and the markers are elevated, then it's very useful, as we mentioned previously, in terms of surveillance or response to therapy or treatment of the disease recurrence. The other role, where if you look at a tumor marker in the setting of lung cancer, like a CEA, there is evidence out there they have a prognostic role as well. So we may have an early stage lung cancer that has undergone definitive treatment with surgery, and as we all know, we use the TNM staging, right, or clinical staging TNM. But TNM is very useful, and like all cancers, lung cancer, the outcome, you can tell we're doing it from SJMC. The outcome, the prognosis is very much treatment dependent. Sorry, the treatment is very much stage dependent. Yeah. But the point I'm trying to make is, you may have an early stage tumor that is fully resected, and on the TNM criteria it's stable, but there are other features that may point to surrogates of a more biologically aggressive tumor, like things like visceral pleural invasion, lymphovascular invasion, which is a histological thing. Similarly, so a patient who has an elevated tumor marker, there is evidence and data out there that it may correlate with a more biologically aggressive tumor, and therefore even once the patient has had the cancer fully resected, as oncologists do and McKeown might have a lower threshold to offer them adjuvant, for example, chemotherapy or targeted therapy in those patients who have a elevated baseline tumor marker. So I think for me, as a surgeon, the point we want to get across is there is a role for tumor markers, mainly for disease monitoring, disease recurrence, response to therapy, and possibly for prognostication. But it's not good enough at the present time in terms of, as you say, the purposes of screening as a standalone.
Thank you, Anna. BK, go ahead.
Okay, so I think the gastroenterologist, I think because the other one of the tumor type that produce CEA is colonic cancer. So obviously, upper GI, lower GI investigation were important. But this patient had upper GI and lower GI investigation a year ago and it was normal. So the gastroenterologist actually advised the patient to have a chest X-ray. So the chest X-ray on the same day of the patient's visit was done. As you can see on the screen, there is a shadow in the left lower zone here, just at the cardiac border. So this is obviously speculated lesion. So this is not normal. So the patient was advised to have further investigation in terms of CT scan. So CT scan, and this patient actually went to see a chest physician on the same day. So she went from the gastroenterologist's office, then she attended the chest physician clinic on the same day, and the CT scan was arranged on the same day. And then you can see that on this CT scan, this is a sagittal view, and you can see a mass, a speculated mass measuring about 2.6 centimeter in the left lower lobe, and this is the axial slice that you can see at the left cardiac border. There's a mass which is a slightly irregular margin on the left lower lobe. So we advise the patient that we need to know more about this tumor. Obviously, the differential diagnosis will be, the top differential diagnosis will be lung cancer. So patient went home to think about the options available to her. We advised her to have a CT guided biopsy. And this was arranged on the 17th of December, which is about 5 days later. So the patient went home and thought about it and then contacted us, and then she agreed to undergo the CT guided biopsy as we did, as I said earlier on. And then you can see in the slide, this is a CT guided biopsy. You can see the needle going to the chest wall, going into the left lung, and a sample was taken. So on the 24th of December, the patient came back to the clinic which is about a week later, where the histopathological examination revealed that this is known as a moderately differentiated adenocarcinoma. At this point, she was referred to me for consultation. So when I saw the patient, I took the history, examined her, and she's actually very well. She's totally asymptomatic. She's quite a fit lady for her age. So I advised her that we need to stage this cancer. So we have a histological diagnosis, and we need to do staging investigation in terms of to determine whether how extensive the cancer is, and also as Dr. Anand alluded earlier, the treatment for lung cancer is stage dependent, and of course it's not just stage alone. How fit the patient is, comorbidities, those are important factors to be taken into account. So, we discuss about in localized disease, we have several options such as surgery, radiotherapy, radiofrequency ablation. Those are options available to us. So maybe we can discuss further about options available for this lady in terms of treatment.
You also done a PET scan, John. Do you want to share that PET scan?
So we also did a PET scan. The PET scan actually show localized disease. As you can see that is a black blob, and then this is the color one. So there's no distant metastasis. So this patient truly have a localized disease.
So I think at this juncture, I think it's important to discuss the options that are on the table. And being the first one at the scene, Dr. Yap, maybe you should discuss what option you think best suited for this patient: surgery, radiofrequency, radiotherapy.
I think for me, if patient is very fit and there's no disease outside, I think essentially, in terms of experience, in terms of the data out there, I think surgery has we have the most data in terms of success, in terms of survival, local control, and then if patient generally if it's not fit for surgery, then radical radiotherapy, nowadays we have technology can deliver high dose radiation in a short space of time, in terms of over 1 week, can be delivered. So, but I think the standard of care remains surgical resection if patient is fit for that. So maybe we can get Dr. Anand to comment about surgery.
Maybe get Chua first. The physician first. What do you think?
Right. Okay. So I agree with what Dr. Yap has just mentioned. I think if the patient is operable, actually, if the disease is resectable, and if the patient is medically fit for the operation, then patient should go for a surgical removal. I think that's a gold standard of care. But apart from that, besides what Dr. Yap has mentioned, I also want to bring the idea of interventional oncology. In SJMC, we have got a very skillful and strong advocate of interventional oncology. I think there will be other procedures that can be done. For example, radiofrequency ablation, cryotherapy. But personally, I think this procedure should be reserved for those who who is not fit to go for operation. Then these are the options that's available, right? So to treat this kind of cases.
So obviously, Anand, the two physicians that we have here, Dr. Chua and Dr. Yap, believe that you are the best man for the job for this patient, obviously. But what goes through your mind when you see these cases like this? What are the tests that you need to do to assess suitability, operability, whether they are fit enough for surgery?
I mean, yeah, Martin, it's reassuring that two oncologists and chest physicians, we're all on the same page. I think this is global standards. Standard of care is still for localized disease, stage 1, stage 2 disease in a medically fit patient. Surgical resection is still the gold standard of care in terms of curative intent, in terms of long-term surgery. And one of the other things that we do with surgery, where any lung cancer operation should be performed, if it's done properly, is in addition to resecting the primary tumor to achieve control, the surgeon, he or she must endeavor to do what we call as a systematic lymph node clearance. And that is going to and staging as well. Obviously, for patients, as both Troy mentioned and KC mentioned, were medically inoperable or were refused surgery, it's still the patient's prerogative. Then we explore the non-surgical options as well. In terms of, as a surgeon, or what any surgeon needs to decide, I think this is very useful for most of our audience, our colleagues in primary care. For me or any surgeon, it's fairly simple. There's two questions that need to be answered. One is, I think Dr. Chua mentioned that in passing. One is the operability of the patient, and the other is resectability. So when we talk about resectability, if we start with that first very briefly, we're talking in simple terms whether the tumor can be removed completely, can be removed safely. And for that, I don't really need to see the patient. I just need to look at the relevant imaging, which is usually starting with chest X-ray, then a CT scan, contrast enhanced CT scan, and certainly a PET scan to try and determine whether this tumor can be removed completely safely, which is technically feasible. If the tumor is deemed to be resectable, then the key is to establish the patient operability, which again, as we all know as clinicians, is their fitness for surgery. And here is where we look at a few important investigations. Certainly, I would need to see the patient. We look at the age of the patient. Bear in mind, of course, chronological age doesn't always correlate with biological age. We look at the pulmonary function. So we usually get a baseline spirometry to have a look and ensure that this patient has sufficient pulmonary reserve to tolerate the required resection, whether it's wet resection or the gold standard lumpectomy, or occasionally, very rare these days, but we have to do lumpectomy. Now, we also assess the cardiovascular status, usually with a baseline ECG, and I always get an echocardiogram, and most of my colleagues would as well. These patients tend to be a bit older, there are a lot of comorbidities, concomitant smoking risk factor. Finally, we look at the nutritional status. Sometimes this is just an end of bed or in the clinic sort of end of couch assessment. To be more objective, we can look at the body mass index, we look at the serum albumin, and of course performance status, which I think oncologists are far better than us. But we've got to make sure this patient is motivated, they're mobile, good social support. So, the two have to come together. We need a resectable tumor in an operable patient so that hopefully will deliver a favorable outcome.
Very good, Anand. So because we have got the CRT as well, and one of the options that he has mentioned there is radiation therapy. Maybe you can allude a bit to that, Dr. because it is one of those important advances in recent years with regards to radiation therapy, or this thing called SBRT.
Yes, thank you, Martin. I think nowadays we have technologies in terms of radiation delivery technology. We can deliver very precise and high dose radiation to a very focal area, and that will destroy the cancer. So we actually have that kind of equipment and machinery in this institution. And usually patients who are medically not fit for surgery, we will certainly offer that as an option, provided they can lie down. I think, in order for a patient to have radiotherapy, they need to be able to lie down. I mean, if they have very bad chronic obstructive airway disease, then they cannot lie down, and that's not feasible to have radiation. So the SBRT or stereotactic body radiotherapy, typically we can give 3 to 5 up to sometimes 10 treatment on a daily basis. If we feel that the tumor is small enough, then usually we reduce the number of the treatment. But if the tumor is quite large, then we have to what we call fractionation. We have to give a bit more in terms of the number of treatment. So the side effects, I think that's what most people are worried about in radiation. In fact, radiation is X-ray. We use high energy X-ray to treat the cancer. And generally, it depends on what you irradiate. If you irradiate a small part of the lung, then in terms of your lung function, it should not be too badly affected. You shouldn't have any problem in terms of breathing. Usually, this kind of treatment lasts for about 5 minutes or so per day. So if they have 3 treatments, so they come on consecutive days, 3 days, and then on a daily basis. So it should last for about no more than 10 minutes. So usually it's quite a short burst of radiation that we give to them. And certainly when the patient leaves the radiation machine, they will not be radioactive. I think a lot of people think that they may glow in the dark or they be radioactive, they cannot sleep in the same room with their family members and so on, but that's not true. Once the radiation machine, we switches it off, then there's no more radiation. So in terms of side effects, again, generally speaking, the skin may get a bit of like sunburn effect. They may have a little bit of a cough due to the radiation-induced pneumonitis, but that's usually short-lived and it can be managed easily.
I think, Sharif, we're borrowing from what Anand said. Resectability and operability. If you have a resectable tumor but a non-operable patient because of premorbid conditions, this is where SBRT might be useful. Of course, the local therapy intervention oncologist may be also useful in this situation. Dr. Yap, can you go ahead with your presentation further?
So obviously, she was referred to Dr. Anand for our surgical opinion. And remember, I saw her on the 24th of December. So Dr. Anand was on holiday. So I think when she returned, then the patient saw him on the 2nd of January. So it's a few days later. So obviously, she was assessed for her fitness for surgery, and she had pulmonary function test, an echocardiogram, and anesthetic assessment. So then she was deemed suitable for surgery. Dr. Anand, do you want to comment about what happened during surgery or recovery and so on?
Thanks, BK. So yeah, I mean, I think they've staged her, as you said, based on the CT and the PET as a stage 1A, as well as stage 1 stage for lung cancer. And I think this was a 2.7 centimeter tumor. So that's a T1T N0 M0. So it's a stage 1A3. Stage 1A is subdivided into 1A1, 1A2, 1A3 based on the size of the T descriptor. So early stage disease, we saw the images in the apical segment of the left lower lobe near the oblique fissure, technically resectable. It was uneventful operation. The operation of choice that she had was a lobectomy and just continued dissection. And if I remember correctly, she had a pretty uneventful post-operative recovery. Maybe we share the histology.
Okay. So the histology was a 2.7 centimeter moderately differentiated adenocarcinoma with involvement of the overlying flora. This is like a prognostic indication. The all 7 lymph nodes removed were clear, so pathologically this was staged at stage 1B. So after that, we actually requested some molecular testing, and in terms of EGFR mutation, this is a common mutation in patients with adenocarcinoma of non-small cell origin. And then we have nowadays new treatment in terms of targeted precision medicine, in terms of targeted therapy. So maybe we want to discuss a bit about this issue.
Yeah, I think, yes, in this situation, there aren't any other metastatic disease. Tumor was completely resected. So whatever options of treatment that we have at this point in time is adjuvant therapy. So maybe Dr. Chap, we can talk about adjuvant therapy in this patient first. What are the options that we have available?
So adjuvant therapy means that, after the radical treatment, which is radical means curative intent, then is there any treatment which can be offered, could help the patient to prevent cancer recurrence and hopefully can also prolong life? I think this is what adjuvant therapy means. So adjuvant therapy means that giving treatment for patients who are so-called clear of the disease. Of course, we cannot be certain that they may have microscopic disease. So most of the adjuvant therapy, the whole idea is to treat potential microscopic disease that we cannot see with naked eye. We cannot see them on PET scan. We cannot see them on CT scan. So this is the option of adjuvant therapy. So any adjuvant therapy, hopefully what we like to offer is low toxicity, so that is effective, that has evidence that it can prevent cancer recurrence. So for this type of cancer, adenocarcinoma, it is associated with about 40 to 50% chance of something called EGFR mutation. This is a common mutation in this particular subtype, and we have very effective treatment in terms of what we call tyrosine kinase inhibitor or TKI, which can inhibit this particular mutation. And this there has been some study which I can go on later to in terms of evidence why we think about this may be suitable for patients.
What do you think, Chua and Anand? Because for the longest time, patients post-surgery for life with very minimal benefits. And obviously with this TKI, things have improved by leaps and bounds, I must say. But what's the take from the chest physician and the thoracic surgeon with regards to the role of this modality?
I think, yeah, historically, adjuvant chemotherapy was a treatment of choice for patients who have undergone surgery but yet with a higher stage disease. But I think this treatment, this tyrosine kinase inhibitor is coming into the picture. But historically, again, this is used for more advanced disease. But I think we also should take the opportunity with the evidence coming in, of course, to treat patients with this new treatment. Because I think a lot of us have seen with our own eyes about how good, how effective, and how lack of side effects this treatment is. So I think it's very beneficial for our patients.
I think, Martin, yes. In terms of, if we look at this patient, stage 1B, preoperatively she was stage 1A3, T1C and non. And then, as Dr. Yap mentioned, she went up because of visceral pleural invasion, automatically led to T2. So without going into too much detail, that makes it stage 1B. And I think, as you mentioned, we know from a lot of data historically, stage 1B, adjuvant chemotherapy, as Dr. Yap has mentioned, to minimize or mitigate the risk of recurrence. Roughly, it's about a 4 or 5% survival benefit in 5 years. EGFR mutation, new kid on the block, very exciting. We are definitely seeing, much higher incidence in Asian populations compared to the West. Maybe 40–50% of these expression in adenocarcinomas. And, for us as surgeons, you resect the tumor, early stage disease, macroscopically, microscopically, margins are clear, done a normal clearance, and they all have surveillance. Collectively, all of us monitor these patients in 6–12 month intervals. But it is devastating when 2, 3, 4 years down the line, we have a recurrence. What that tells me is, across the world at this time point, our methods of staging still aren't good enough. That there's microscopic disease that the CT and PET scan can't pick up. So if there are treatments, in this setting, targeted therapies or mutations that are amenable to this, then I think certainly this is the way to go. I'm sure Dr. Yap will share with our data, which I think shows very good progression-free survival, right? Okay. Even the stage 1B and above for resected disease. So I'm definitely a strong advocate. I mean, the way I practice very simply is I will ensure that the patient post-surgery sees an oncologist to get an independent and an opinion in terms of whether there's any potential benefit. I think that decision has to be individualized. Yeah.
I think the other important point is even in patients who are operable with the intention of cure, and if you don't follow up with further treatment, the chance of recurrence over a period of 4 or 5 years is quite high. We're talking about 50–60%, even supposed to be radically treated. Dr. Jack, can you share with us what you have done?
So I think with the recent publication on this, there's a TKI called osimertinib, which is a oral medicine which you take 1 tablet a day. And this study called the ADORA study, which looked at patients who are fully resected, stage 1B to stage 3, and they were randomized to receive either the osimertinib or placebo for 3 years. So it's an oral medication, 1 tablet a day. And this medication, we have previously used it in advanced non-small cell lung cancer with EGFR mutation, and the side effect is very minimal. And usually they can get a bit of skin rash, but the skin rash is quite minimal also. So that is why they can go on to take it for a long period of time. So this study actually showed that in terms of at 2 years, the patient who received osimertinib, the disease-free survival was 90% as compared to 44% in the placebo group. So this is quite a dramatic difference in terms of those treated with this compound compared to placebo group. So in my patient, so if you look at her post-operative CEA, remember she had surgery in January 2020, and she started off with a CEA of 35, and then post-operatively it was 25, and then in May when she was reviewed in my clinic, it was 27, and at that time we felt a bit worried, so we arranged for her to have a PET-CT scan. Again, the PET-CT scan showed no evidence of recurrent disease. So we discussed the option of osimertinib based on the evidence, and she started the osimertinib in July 2020, and you can see that the CEA marker gradually comes down. So she's been on the osimertinib for more than 6 months now, and then we repeated her PET-CT scan in December 2020, and she continues to show no evidence of recurrent disease. So I think what I would say in terms of what we can learn from this case is that in terms of managing lung cancer, we need a multidisciplinary approach, and this really involves many doctors, many specialists, including the chest physician, the radiologist, the interventional radiologist who will do the biopsy, oncologist, cardiothoracic surgeon, nuclear medicine physician who reports on the PET-CT, anesthetist, pathologist, cardiologist. I mean, there are so many people involved in one case of lung cancer. So really, we should really do this as a multidisciplinary approach. And one remarkable thing about this, what I'm trying to illustrate, is that the speed of the treatment from consultation to treatment is within 4 weeks. So it's important for lung cancer patients to be treated in a timely manner because it takes time to arrange investigation, to get the diagnosis, and then to see the right specialist for the right treatment. So I think for this patient, she came for consultation, and within less than 4 weeks, she had a surgery.
Okay, so basically, if you have a patient with cancer, with any cancer diagnosis, time is of the essence. So you've alluded to the fact that you're very satisfied the way things turned out for this patient. And we've alluded to the fact that this patient was asymptomatic when she presented with a raised cancer marker. And which brings us to a very interesting topic with regards to screening, because we know that screening for breast cancer, screening for cervical cancer is par for the course, standard practice now. But screening for lung cancer is becoming mainstream. And I would like to ask Anand to share with us what his thoughts are about screening for lung cancer. Who should you target screening to, and what are the tools that you have at your disposal to get an early diagnosis?
Thanks, Martin. So mindful of the time, I'll just try and give a very brief overview in maybe 2 minutes or less. As you say, the disease burden for lung cancer is very high in this country, and around almost 95% of cases are picked up in stages 3 and 4, where the outcomes are not so good. And despite all these advances we've heard about the targeted therapy, immunotherapy, unfortunately they remain non-curative. We're getting patients to live longer and better, but it's not curative. So the whole aim is to try and pick up the disease earlier, i.e., screening, pick up the disease earlier, where asymptomatic patients are in the preclinical, pre-symptomatic stage. So I think we all accept and agree that to screen for lung cancer with a biomarker, a tumor marker, at the present time is not good enough. The gold standard for screening really is in terms of using the low-dose CT scan. So a chest radiograph, unfortunately, a chest X-ray, while it's extremely useful in many other situations, for the purposes of screening for lung cancer, it's not good enough. The tumor would have to be quite big for it to be visible in chest radiograph. So low-dose CT scan is the way to screen for lung cancer. And the low-dose CT scan is a non-contrast scan, so your patients don't need to mask, they don't need to have a granular inserted in, they don't need to have a baseline renal profile check. They can come in at short notice to any major hospital, public or private, and get that scan done. Rapid acquisition, so even older patients who can't move the breath, a single breath scan takes 10-15 seconds to do. It's non-contrast because we want to look at the lung parenchyma to try and see if there is any suggestion of early stage lung cancer. Now, the evidence-based screening for lung cancer is strong. There's two major trials. First, believe it or not, was a national lung screening trial, which, believe it or not, was 10 years ago. It was in 2011, it was published in the New England Journal, a North American trial, which showed that there was a clear survival benefit. They were able to reduce the lung cancer-specific mortality, relative risk reduction of about 20%, when they randomized high-risk individuals who were essentially smokers or former smokers, aged 55 to 74, in a certain smoking duration of at least 30 years or more. And they randomized patients to either 3 consecutive low-dose CT scans and chest radiographs, and there was a clear survival benefit. About 7-8 years later came the other major trial that provides, again, level 1 evidence to support this concept of screening for lung cancer with low-dose CT scan, and that was Nelson, which is a European study from the Netherlands and Belgium, and that showed even better outcomes in screening compared to the national lung screening trial. That showed a 20% relative risk reduction. Nelson showed a 26% reduction for men, and anywhere between 40 to 60% cancer risk reduction for women over a period of 10 years. So strong evidence to support screening. The last thing, just to share very briefly, because it's quite exciting and something that will be a relevance here, is that all the trials have so far focused on smokers or former smokers for obvious reasons. There is a major risk factor for lung cancer. But just last month, at the World Conference for Lung Cancer, a virtual conference in Singapore, the group from Taiwan, the Ministry of Health in Taiwan, they reported their results of a big study which showed that it is feasible and possible to screen high-risk non-smokers with a low-dose CT scan. And basically, they define high risk. These were people who had either first, second, or third degree lineage, family history of lung cancer, who had exposure to passive secondhand smoking, or what they term as a high cooking index, which was indoor wok cooking without proper ventilation. So it's a bit rough, but I hope that I think you know my thoughts on that. That screening is the way to go, and the way to do it is with a low-dose CT. The difficulty is to work out whom to offer screening to, and in terms of the duration and frequency of surveillance. But that's a totally different discussion. We don't have time for that.
Thank you, Anand, for that. Do we have any questions in the
You want to show the questions in the audience?
Yeah, if there are any questions, because we got a second case that we can discuss, but we may not have enough time to discuss it fully, though.
Okay.
So if there's any questions, maybe we can address those questions first.
Let me get the presentation out now. Not many, but I'll share the. So Dr. Kaur asked, can clarify a bit what's low-dose CT lung scan? And?
So it is a low radiation dose. I think it's, trying to recall, I think it's about 10 or 15 millisieverts, so it's very low radiation dose. It is a fraction of what a conventional contrast-enhanced CT scan would do. Obviously, for staging, you need a contrast-enhanced CT scan, but for the purposes of screening, a low-dose CT scan is sufficient. And as I mentioned, we can send the patients, they don't need a mask, they can just walk in and do it. Very low radiation. And actually, we are on the threshold of the next generation ultra-low-dose CT scans as well.
People can't hear us, but I think our audio check seems to be all right. Maybe your volume needs to be louder, yeah? Okay, there's another question. Can you please comment on the use of circulating tumor cells and genetic testing for lung cancer screening for at-risk population and patients' relatives.
Want to address that, Dr. Chua or Dr. Yap?
I think circulating tumor cells is still a research tool. So I think, certainly it's available in a research institution, and I think it's not for prime time yet, because I think the technique and the how you measure the circulating tumor cell is still, different technique, different machines may give you different reading. So I think this needs to be validated in clinical trial before it comes to clinical practice. And I think certainly at this point in time, I do not use it in terms of, I think there is a role in the future once we kind of finalize that this is a unified way of measuring it, and we need evidence that it actually makes any difference to our treatment strategy. I mean, essentially now what people are use circulating tumor cells to see whether they need further treatment and to detect cancer recurrence. But I think these are new to us. It's not available for prime time yet.
I think on the same vein, Vicky, there's a question about molecular testing. I think can we just scroll down on that same question just now? Comment on circulating tumor cells and genetic testing for lung cancer screening for a risk population and patients' relatives. What are your thoughts on that? At risk population, there's no testing, isn't it? That currently available, unless when you're talking about low dose CT scan and all that. But I think maybe more importantly, I think the role of genetic testing in the lung cancer specimen itself, molecular profiling of the cancer itself. Maybe Dr. Yap can allude to that.
I think molecular profiling is actually useful in some lung cancer. I think, especially molecular testing like EGFR is one of the mutations that we know, but there are many more mutations that we have learned over the years that it may exist before treatment, or it may be acquired. Let's say for patients who actually take TKI for a period of time, they may have acquired a new mutation. So I think certainly nowadays we have many new targeted therapy that can target different mutations. So in terms of what I do is if patient has disease progression after say one TKI, then we can then do further molecular testing to test for other mutations that may be a target, may be targetable. So I think that is something that we routinely do now in clinical practice.
You want to tackle the last question before we go presentation?
Yeah. We got time for presentation.
We can go past two, or you want to go to the next presentation?
So maybe just one question there. Type of lung cancer that respond to chemotherapy and radiotherapy, should radiotherapy be done first before chemotherapy? So maybe that comes with the staging and so on. Want to comment on that, Dr. Yap? I'm taking the easy way out.
I think the certainly it depends. So for stage 3 lung cancer, the best evidence of cure is actually concurrent chemoradiation. And sometimes we do use chemotherapy first because the tumor is very large, patient very symptomatic and not fit for radiation. So we may use chemotherapy first and then reassess the patient after chemotherapy whether they are fit for concurrent chemoradiation. But if not, then they give chemotherapy and then followed by radiation. That is a feasible. I think how you give it and in the sequence you give it is quite complex. So obviously it comes from the oncologist. I think it depends on the stage, it depends on the patient's business.
Thank you.
Martin, just on the point about sequence of treatments, because this first case I think illustrates also not just the value of screening, but the use of TKIs. Just to share as well that sometimes the TKIs are given in the neoadjuvant preoperative setting. So we talked about resectability, and a number of cases where the tumor initial assessment doesn't look resectable. Technically very close to major blood vessels. And as Dr. Yap mentioned, we get the molecular profiling. And for example, there's an actionable mutation like an EGFR, they've been given neoadjuvant TKI, and we've seen very, very dramatic response of that downstaging of the tumor to then make it technically resectable. And then we go on to do the surgery. So very exciting that, I think it highlights a multi-modality approach. Sometimes we're delivering this pre-operatively, pre-surgery, the neoadjuvant setting, and sometimes it's post-surgery. And the point that multidisciplinary, multi-modality. So great potential.
Yes, it really points to the fact that every case is different in its presentation and itself and its management as well. I think we'll conclude the first case, and I would like to invite Dr. Chua now to present the second case.
Okay, right. Thank you, Dr. Mellon. Right. So I've been tasked to present the second case, mainly because this patient came to see me first. But yet, this another patient that showed that how this patient goes around SJMC and seeing many consultants, needing a multidisciplinary approach or input, right? So, but since I'm presenting the case and being the respiratory physician, I think the focus is going to be a little bit more about the diagnostic process of this case. So, okay, we'll get on. Right. So now this is a gentleman who is 56 years old, right? So he never smokes, right? But he has got hypertension, hypercholesterolemia, and diabetes. Right, another thing to note is that he may not have been looking after himself very well. His HbA1c was 10.9%, 10.5%. Right, so in October last year, he actually presented to another private hospital with a stroke. Right, now during the initial treatment and management of his stroke, he had a chest X-ray done. So the next slide is going to show us his chest X-ray. Right, so while this is not a quiz, like an ECG quiz, so I'll just go on to explain this X-ray. The most obvious abnormality on this X-ray is actually in the right upper zone. If my mouse could move a bit, right? So now there's some ill-defined opacity or infiltrate in the lateral aspect of the right upper zone. Right, there's a more obvious abnormality. Right, so with this, okay, so we'll move on to the next slide. Right, so what the physician over in another hospital, the other hospital did was that he did this tumor marker. So we can see that I've typed the result there. Basically, both the CA and 19.9 were elevated. Right, so then he went on. I mean, because of this tumor marker, then we went on with the next slide. Then what we see now is actually the CT scan, right? So now we can see on the left lung, right? So in the left lung, the ill-defined opacity on the left lung was what we saw on the chest X-ray. Actually, some of you may notice on the left lung there's a lesion there, right next to the arch of aorta. This one here, yeah, it's well demarcated, right? It's spiculated. And is irregular in shape, right? So the next slide actually shows the mediastinal window, right? So again, showing that there's a soft tissue mass. Okay, it's a mass with a low soft tissue attenuation, right? So actually, the next slide will bring us back to the X-ray. So I bring back this X-ray. It's the same X-ray 3 slides ago. Actually, in this X-ray, we could see there's actually a faint opacity next to the arch of aorta. Right, not very obvious, but it was there, and on the CT scan, right? But obviously, a good radiologist will not miss that. Well, then we move on. I'll show you a few more cuts lower down. So I basically on the CT scan, you can see the right lung is still very ill-defined, patchy, right? Nodular, some area nodular a bit. And then the left side still show the same mass-like lesion, spiculated mass-like lesion. We move on to the next slide, the soft tissue window, showing the same thing, right? And I think there's a further lower cut, right? So now on the right lung, when the lesion moves lower down, it becomes a bit more solid, right? So the area that is a bit more solid, okay, but still surrounding the lesion, there's still some kind of infiltrate, which looks a bit thin but infective-like. Whereas the mass on the left lung is getting smaller now. It's coming to the bottom end of it. Right, there's a soft tissue window, right? So and then further down, there's again showing the same thing. The ill-defined infiltrate in the right lung, right, and the left lung lesion is coming to has come to the end. We don't see the lesion anymore. So at this stage, so with this, he came here because the other hospital did not have a respiratory physician support. So he came to SJMC as an outpatient. I saw him on the 12th of October, right? So 2020, I'm afraid, sorry about that. So he had no respiratory symptoms, right? So there was no cough, no sputum, no hemoptysis, no SOB, no chest pain. He has lost a lot of weight though, right? So he lost about 30 kilos. So from quite an overweight man, he slimmed down quite a lot. But he claimed that this was intentional, but I doubt so. I think the HbA1c of 10.5 contribute, and whatever going on in the lung now contributes as well. He also admitted to a TB contact, right, which happened a year before he came to see me. Respiratory examination was unremarkable. Right,
so
the next slide.
If I could stop you there.
Yeah.
What would be your comment in regards to his presentation? He seems to have a lot of things going on in the lungs, yet his symptoms are very, very minimal.
Yes, correct. In fact, there are no symptoms.
You got no
There are no symptoms. Whatever we are seeing now on the X-ray and the CT scan are all incidental.
And interestingly as well, the cancer markers again was done, despite all your thoughts about
No, sorry. I forgot to address you, sorry. Thank you, Dr. Mellon. Now, this will be the time I might consider doing a tumor marker. Because you see, it's different from when I said earlier, I don't agree to use tumor markers for screening purposes. But now we are not dealing with screening. We found something. We found an abnormal imaging, right? And at this stage, we are not too sure what it was. So a tumor marker helps a little bit to guide our direction of investigation, whether it's going to be infective or malignancy. So, but bear in mind that in this case, it's elevated. So the possibility of malignancy goes further up in the differential diagnosis. But my point is also that even if it returns as negative, we shouldn't exclude malignancy in the list of differential diagnosis.
I think that's an important point to make. Again, stressing the fact that sometimes symptoms are very minimal. From the chest physician point of view, what kind of information do you want to pass on to practitioners? Symptoms that you want to elicit that might actually raise red flags.
Right. Well, I mean, obviously, we all know that when we base on symptoms alone, right? Patient tends to present late for lung cancer. They come to see us with symptoms. They are 90%, according to Malaysian data, it's going to be 6, 3, and 4, right? But anyway, I'll go through the symptoms of lung cancer. I mean, they could have chronic cough, they could have hemoptysis, they could have lost weight, they could have chest pain, they could have SOB, deep breathing difficulty because of profusion. They may present with a stroke-like illness because of brain mets. But in this case, it's an ischemic stroke. There's no brain mets on the scan, on the brain scan. Right. So, but obviously, along the way, it's also important to get a smoking history. In this case, this patient has never been a smoker, right? And also, family history of lung of CA of cancer is also important as well. So, if we see someone with a chronic cough, right, of which with minimal history or minimum symptoms, then I think all this history, other history, as smoking history, family history, may help to guide us to see if we need to be more aggressive or we need to carry out further investigation.
Okay, go on, Dr. Shra.
Right. So now, with all this information I've shared with you, right? So we come to the differential diagnosis part. Right. So obviously, we found basically patient had no symptoms, right? They had no symptoms, but yet we found some incidental findings on the X-ray. So what are we dealing with? Number one, it may be metastatic lung CA. Basically, I'm referring to a left lung CA with metastasis to the right lung. It may be a synchronous CA. Basically, we are dealing with two different cancers, one on the right and one on the left. And the next one I put down is actually it may be a different pathology in each lung. Basically, one side can be malignancy, the other side being inflammation, or one side being infection, and so on. And the fourth one, I say others, maybe it's just disseminated TB. Right, so I think with this, we can go to voting.
You want to vote? Maybe no need.
No need. Okay, because of for the interest of time, I think we'll carry on. Right, so
What now in your thought, Chua? When you look at all these cases, in this case when you saw this patient, what's foremost in your mind to be the real diagnosis?
Yeah. Look, I mean, obviously I have the luxury of having a CT scan when I first saw him, right? When I cast my first eye on the CT scan, the thing I tell myself is, look, it's very odd. It's very odd because as I show you that the left lung is almost beyond argument. It's a mass-like lesion. There's no air bronchogram. It's spiculated. Okay, it's well defined with a well-defined margin. So together with the raised CEA, I was quite sure at the time the left lung was going to be a malignancy. But when I look at the right lung, that's where it becomes a bit unsure. Mainly because the right lung, what I show you and what I explained to you earlier on, is that actually the changes is more of infective changes, right? It's very ill-defined. It's very ill-defined with no specific margin. Even in the more solid area, in the lower part of the area, it's more solid, but we could just about see an air bronchogram within the mass. So that's why at that time I was thinking that, hey, look, we may be dealing with two different pathologies here. Maybe, just maybe, the right lung there is an infective process going on in the right lung, whereas the left lung is almost definitely a malignancy. So that's why when because definitely patient will need a biopsy. Definitely I bring up the issue and I go through the scan with our very good interventional radiologist. So this person agreed with me, saying, hey, look, yes, the lesions look very different and we need to do a bilateral lung biopsy, right? This is not something common, right? This is not something we commonly do. Maybe because it's not common to see this kind of CT scan appearance, and bilateral CT-guided lung biopsy carry a higher risk, right? Imagine if someone, after biopsy, bilateral biopsy, and with bilateral pneumothorax, a patient could collapse on the table. But obviously, we have very good interventional radiologists here, and we have discussed the case. We have come up with a plan to do this procedure, this bilateral lung biopsy safely. I will spare you from a detail, but basically there's preparation to do. So with that, we move on to do a biopsy, and the lung biopsy was done on the 19th of October because we have to stop the antiplatelet for his stroke. And then when he came back when he returned for follow-up on the 22nd of October, right? The biopsy report confirmed the suspicious of two different pathologies. Mainly the left lung biopsy actually came up with adenocarcinoma, not surprisingly. But in the right lung came up as a caseating granulomatoid inflammation consistent with TB. A few days later, the TB PCR of the right lung biopsy turned positive. So at this stage, right, so we have confirmed that this man actually has left lung CA and the right lung TB. Right, so from there, because there's no other evidence of lesion elsewhere, so I requested a PET scan on the 27th of October. The next slide shows the PET scan. Basically, we can see on the left lung, there's a FDG avid lesion. Right, my mouse can move a little bit. There we go. So this is FDG uptake, showing the location of the cancer. But we can see on the right-hand side, right, the infective changes they confirmed with TB earlier on. You can see the more solid area hasn't got much FDG uptake, right? There is some, yes, but it's not even close to the left lung lesion. So this is consistent with infective changes, a bit more active, but not as active as the left-hand side. Right, so actually there's actually apart from the left lung lesion, there's also aortopulmonary window lymph node metastasis. Because there's only two lesions, okay, after I discussed with the cardiothoracic surgeon, which is Dr. Anand, we agree that this lesion is resectable, right? And hence I refer the patient on to Dr. Anand.
Okay, thank you, Dr. Chua. Anand, you received the patients? What did you do?
I said thank you very much, Dr. Charles, sending me a very bizarre, complex case. No, I think a few important points this case highlights. The first thing, as Dr. Charles mentioned, is we have to keep an open mind. You can have dual pathology, and certainly the PET scan is very helpful because we get differential uptake, FDG uptake. There are cases when you can have two different cancers. We talk about synchronous tumors, and when you can have also a tumor that is quite necrotic and has always ametabolic, minimal uptake. Equally, you can have inflammatory conditions like TB, where there is high FDG ability. So at the end of the day, I suppose you need histological confirmation, biopsies, which is what's done. With this particular case, you know, if you have a tumor in one lung and you have spread elsewhere, it's quite uncommon in this scenario to go to a contralateral lung, as we know this wasn't the case here. But one of the things I would look for is mediastinal nodal involvement. So if there's no mediastinal nodal disease, it doesn't mean that you can't get a lesion in the opposite lung, but it's less likely. I think the PET scan showed no disease elsewhere. But this also illustrates an important point. The CT PET, the CT component of CT PET is a non-contrast CT. And when we are trying to determine the resectability of a tumor, in other words, can you remove the tumor, we need contrast on the CT component to delineate the mass, the tumor from the surrounding structures. And it wasn't shown clearly in the slides in this presentation, but the left upper lobe lesion was contiguous on the contrast-enhanced CT. There is no clear tissue aid with the pulmonary artery. So at this time point, that tumor in the left lung is technically not resectable. And of course, we have the setting of active pulmonary TB in the contralateral opposite right lung. So, I felt that this wasn't a resectable tumor, and we also felt we needed to treat the tuberculosis challenging, and we was referred on to Dr. Yap, an oncologist, to explore whether there was a possibility of non-surgical treatment with the view to downstaging or downsizing that left lung lesion in the hope that it would be resectable, and in the interim, use that time to start anti-tuberculous therapy. I am mindful that if you were to get chemotherapy that suppresses the immune system, it can also lead to more florid TB. But from a surgical perspective, the left lung lesion was not technically resectable, which unfortunately is not well demonstrated in the slides we have.
So you then get Dr. Yap to see the patients?
I did. I think I can't remember the sequence, whether it was back to Dr. Chua, but I think between us, we felt once it was established that this is not something that is amenable or it's not in the patient's best interest to operate.
At least not in the
first instance.
Okay.
Then he went on to
So he came to see me. So we actually perform a molecular testing. So he actually has EGFR mutation. So we discussed the option of downstaging it with TKI, and then if it's smaller, then we will revisit to see whether the tumor is operable at that time. He had about 2 months course of the TKI. Unfortunately, he developed further stroke, and he had also had myocardial infarction. So I think, surgery, of course, in somebody with recurrent stroke and a recent MI is going to be difficult. So currently, he continues with his EGFR TKI product.
Have you assessed how had he responded to the TKI?
So I think at 2 months time point, the tumor hasn't changed, but the CA has come down. But I think it's just too early to assess at the moment. So I think he continues with his TKI for now. Then certainly, later on, I will reassess his condition and hopefully he will recover from his recurrent stroke and his MI. So you can see that this case really illustrates a very complex, multiple medical conditions. He had TB, he had cancer, he had stroke, he had heart attack. So obviously he has to see many specialists. He has to see the neurologist, he has to see the rehab doctor, he has to see the cardiologist, the oncologist, the cardiothoracic surgeon, in terms of and all the investigation that we have obviously requires other specialists to be involved. So again, in this case, it illustrates the importance of multidisciplinary approach in dealing with lung cancer and other conditions associated with this comorbidity.
Martin, if I can just add one more comment. I think Dr. Chua did very well, because this is important that we don't relegate the patient to, he had a biopsy, he was diligent to pursue a biopsy on both sides. Because if you got a biopsy on the left lung, which is the obvious one, and confirmed that you have a non-small cell lung cancer, but if we then made an assumption that the lesion, that ill-defined lesion on the right, was malignancy as well, then you would automatically put him at stage 4. But you were quite diligent and meticulous in working him up, biopsying both sides, getting the PET scan. And the reality is, in terms of staging, it's still earlier stage disease, but it's locally advanced. And the reason he wasn't offered surgery, as we mentioned, is because there's no margin from the main pulmonary artery, which again is not illustrated there. So it's a technical issue, but at least we didn't relegate the patient inappropriately. So I think it's important as a learning point for all of us that we've got to be very meticulous in how we stage patients. Sometimes it involves invasive procedures and sometimes less so. That's important here, as you highlighted, dual pathology as well. So that's important.
So if I may ask, in your discussion with the interventional radiologist, of those two lesions, which one is more safer to biopsy? To my mind, the one in the right lung is safer to biopsy because it's abutting the chest wall. And if you only did that biopsy, then you're only treating it TB, and hoping the anti-TB will have anti-lung cancer effects, wouldn't it? And it would be disastrous, obviously.
Exactly.
Yeah, again, congratulations, you have been very meticulous and, be able to diagnose those two. So, any other issues that you want to bring up?
Thank you. Stress one more point, because I say I want to focus a bit more on the diagnostic side. I think if we can recall the X-ray I show you, I think for some of us, again, who works in a resource luxury area like what I'm doing now, there, of course I can request a CT scan the next day. But I used to work in government sector as well, right? So I know some places it's almost impossible. It's so difficult to get a CT scan. So if you are hit with an X-ray, like what I showed you just now, and patient got no symptoms, right? It's difficult for to tell whether it's going to be a bit more TB or whether it's going to be more CA. I think this is the time that CA, I stress, tumor markers may come to my mind. I will do this blood test, these tumor markers, to help me to guide my working diagnosis at that stage. Right? Nothing beats CT scan, yes, I know. Right? But I think this will be one of the time. Right? So again, going from here, sometimes I use tumor markers in the cases where when I do a CT scan, I found a lesion, and the patient is elderly, or patient is not keen, if the patient is afraid, is worried about a needle going into the lung, I say, fine, this is the time I'll do a tumor marker, right? And if it's elevated, then I'll strongly advise the patient, yes, you need a biopsy. But obviously, bear in mind for all of us who uses CEA level at whatever setting you are in, just remember a negative CEA, a low CEA level, doesn't exclude CA.
I can just very briefly on that point about biopsies. I need to speak up
because I can't hear you. Yeah.
Just to add on that point about biopsies, so it is, as you mentioned, Martin, sometimes if you have a central lesion close to a major vascular structure, there can be technical issues. Yeah? I mean, patients, the things we worry about, of course, iatrogenic pneumothorax, you worry about bleeding, you may get a non-diagnostic biopsy, there may be a sampling error, there are instances when you have a lesion that is difficult to biopsy, it's speculated, I'm talking about lung lesion, it is FDG avid, and there are instances when patient has been appropriately staged, where it is not unreasonable to proceed to surgery. And what we would do in that scenario is do a excisional wedge biopsy and send it off during the operation, what we call as an intraoperative frozen section, to get histological confirmation of whether this is a cancer or not. So and obviously you have pre-discussed this with the patient and family, taken the appropriate consent, and then you proceed accordingly. So if you've wedged out a lesion that is suspected to be a lung cancer, but the intraoperative pathologist report says it's inflammatory, there's no evidence of any cancer cells, and you don't proceed further. Or consequently, the reverse, if it's confirmatory of a lung cancer, then you proceed with the resection. So there's pros and cons with biopsies as well. I'm not advocating, I'm saying yes, in an ideal setting, you should have the histology up front. But sometimes you may have someone with very emphysematous lungs, someone who, or medical reasons that preclude safe biopsy. Patients are worried about. The other thing I didn't mention was about tumor seeding as well. So these are all, potential hazards with biopsy.
Another question which is interesting to know to ask Dr. Chua is that can you get raised marker tests in active TB?
It can be false positive, definitely.
That means a patient who's got TB and cancer markers can be raised as well?
Well, in theory, yes. I mean, personally, I haven't come across such case. Because you see, CEA can be raised even in a normal person who doesn't have any active illness.
Very good question.
Yeah. Okay, I think those two cases that have been presented actually illustrate a lot of the principles and thought process that goes into the management of patients with lung cancer, starting from the early cases to the more advanced case. And I think, are there any questions from the audience, Dr. Tay?
Yeah, just a few more if you want to tackle.
Do we have time?
We always got time, whether people want to, are waiting for their CBD points.
Okay.
This part is very loud and clear. The points are coming. Hang on.
One point.
Okay, maybe we can address some of the questions that that have been asked.
Okay. Maybe, I'll just show the poll again before we go on to questions, because before we started, majority opted for chest X-ray as screening. And after listening to the team here, which of the screening methods you would like to choose for lung cancer?
CT scan, 100%?
Only 2 have voted.
Only
and
2
more votes, please. If we don't have more than 10 votes, the points are not coming, huh?
Get voting.
So I think, I remember, Katie, you gave a talk to GPs. I think Anand was there. We were talking about oncology, a one weekend session organized by SJMC. And I think your comment was there's no role for chest X-ray for screening for lung cancer.
That's right.
Is that right now?
Yeah, that's right. I mean, it still applies, yes.
I mean, that's what we were saying, Alan. Chest X-ray is incredibly useful for lots of other things. But for the purposes of screening for lung cancer, yes, we're in 2021, it's just not good enough for that. And it shouldn't be used for that.
And with low dose CT, we shouldn't be worried about the radiation exposure, and the cost is also lower than the regular CT now, isn't it?
Very much so, yeah. And it's widely available, and it's very user-friendly in the sense, like I said, they can just walk in and get the scan done.
So the message is low dose CT.
Non-contrasted,
low dose scan.
I mean, if I can just share the population that we recommend to go for low dose CT screening, and I hope you will push this with your patients in your own practices, are basically smokers or former smokers aged 45 to 75 years of age, who, whether male or female, with at least a 20 pack year history. So we have used the NLST and the Nelson data, and then we have contextualized that with our own local disease epidemiology, looking at the disease burden, age-specific incidence, and so forth. And as I mentioned briefly, the talent study from Taiwan, very exciting because they have now shown that the high-risk non-smoker, it is feasible and it is worthwhile to screen them. So that is the next big thing that will come, because anecdotally, I think about a third of the patients that we all see with lung cancer are non-smokers. In Taiwan, Korea, Singapore, it's closer to 50%. And it's overrepresented in the Chinese. So a common scenario we see is the non-smoking Oriental, the non-smoking Chinese female. Now, obviously, there's genetic predisposition. There may be also, that passive smoking exposure. But we've got to screen. We've got to pick up the disease earlier, definitely.
So now it's reversed. 78% select CT, and we still got to convince the 22%. Maybe it's a question of access. They have a low resource, rural setting, GP clinic in a small town. They don't have access to CT. They have no choice, perhaps, I guess. But it looks like you convinced the majority. Okay, we move on just quickly to the questions for sake of time. Oops, sorry. So we apologize for the sound. I think we did a pre-session audio check, but I think it wasn't loud enough for some of you. We shall do better next time. Anyway, we shall all speak a bit louder. I think you will. There's a question there. Melo, you want to take it?
When is the CEA 35, presumably CEA investigation indicated? I think Chua, you addressed that question early on with regard to the CEA, isn't it? Yeah, so that question is answered. Next question, does low-dose CT scan machine with high slice counts can low-dose sequence produce a quality recognized high-resolution CT? And then you want to comment on that?
I mean, the short answer is yes. The low-dose CT for purposes of screening is very good because we want to study the lung parenchyma, and that's sufficient. When you want to stage the disease and you need to assess resectability, delineate the tumor from surrounding structures, then we need a contrast-enhanced CT, and it will usually include the thorax, abdomen, pelvis as well, and then go on to a PET scan. But the answer is yes, it's good enough for purposes of screening, global standard. That's what we advocate. Yeah.
Okay.
The low-dose CT was covered already.
It's covered already.
There's another question higher up. Lung cancer presenting initially and solely as SIADH.
Okay, so maybe there's a question for Alan Tay.
No, I'm not a metabolic doctor. Yeah, but I think Katie Chow would have seen some cases with SIADH.
Definitely. I mean, I just have one just discharged from SJMC a few days ago, co-managing with Dr. Yap. Right. I mean, yeah. I mean, I would say it's not so common, but it's definitely not rare. It's not rare. But most of the time, as a patient goes on treatment, initially with medical treatment and subsequently with oncology treatment, usually it doesn't become an issue. But I have to say the most recent case I have with Dr. Yap Beng Tiong, I mean, we are having a lot of issue, and I have to call in a nephrologist to come and help me to manage. So yeah, it's something that happens, okay, but not so common. Fortunately, not so common, and also usually not so difficult to treat.
With a small cell that you chance.
This one is small. Speaking to the type, there's another question. With regards to the previous case, isn't small cell CA mostly treated by chemo and non-small cell CA treated by radio? Or is this only a textbook classification?
Dr. Yap can answer that question.
We're taking the afternoon, no?
Of course.
So small cell lung cancer, typically for early stage, is if you can give combined chemo radiation. For late stage, now immunotherapy and chemotherapy is standard of care, so it's quite different. Whereas non-small cell lung cancer, you have to look for the mutation or advanced cases. For early cases, do surgery, radiation. I think that's why Dr. Anand alluded earlier on that the treatment is actually stage dependent and also patient performance status dependent.
I think that summarizes the management of small cell and non-small cell lung cancer. The other question here is to Dr. Chua, I would think. What about the risk of lung cancer in people who vape?
Well, I mean, at the moment, there's no data for such, right? Now, for smokers, people who smoke, for smokers to get lung cancer, it's not going to happen over 5 years or 10 years, right? Usually, we say patient needs a history of 20 PET years. That's when the risk of getting lung cancer increases exponentially, right? So, vaping is something new. Right, so definitely there's data, there's research going on, there's epidemiological study, surveillance going on this vaping. Right, so but at the moment, I couldn't say there's a scientific evidence that vaping leads to lung cancer. But I can tell you that as a group of respiratory physicians, we believe so. I think I can say this on behalf of other chest physicians as well. It's a matter of time we will see this effect. You know, nowadays we are starting to see new terms like what we call VALI, vaping associated lung injury. Now, this is what we are seeing now as more and more people vape in the community, and with a longer duration, then we are starting to see the effects, the ill effects of vaping. So definitely, Malaysian Thoracic Society advocate no vaping. Vaping should be controlled, right? So it shouldn't be just any Tom, Dick, and Harry walk into any shop and can get it for themselves.
Okay. Okay, Dr. Chua. Any other questions, Alan?
No. I will share the.
Okay, if there aren't any other questions, I think it's just for me to thank Dr. Anand, Dr. Chua, and Dr. Yap for their presentation. And I would like to pass you back now to Dr. Alente for the most important bits of the session.
Thank you for your patience. You know, we apologize for the audio. We will do better next time. I think we really need to raise the volume. I hope you could raise your own volume so you could increase the output from our side. For those who ask, we are all in the same place, but we are using a central microphone. So the last time we did, it was quite all right for the cardiology grand round. Yeah. So I'm not sure why this time it wasn't. Maybe it's a setting somewhere we need to check. But anyway, to claim the point, please use your MMA Events app to click on the scan QR code at the top left, as indicated in the picture. The code we are going to display now is valid for about an hour. Okay, so please, if you're watching this like on Sunday or Monday, please don't get back to us and say why the code doesn't work anymore. Please, this is actually designed by the MMA so that the code is not to be abused. It's for people who are actually listening to the talk. So I hope all of you have been listening to the fantastic talk by my oncology team, colleagues here, a respiratory physician, cardiothoracic. You know, I think it's been a great discussion on multidisciplinary management of lung cancer. So I'm going to test and see whether I can scan, and that would be the proof of the pudding, whether or not it works. Yeah. Anybody managed to get?
Yeah, I got it.
Well done.
You got it?
We had some feedback from some users for iPhone. When you are scanning, you don't see the box, the camera box. For the Android, you see a camera box. But don't worry, they are fixing it. There's no camera box for the MMA Events app. You're using the Apple version, but you should be able to still scan. Okay. So click scan QR. There's no box, but you should be able to scan. I've just done it with my iPhone, and I could successfully scan, even though there's no box surrounding the camera. Okay. I did it. Now, even if we end the stream, the code is here. You can always rewind the video and then display the code, because we had some feedback to say, oh, we didn't put up the code long enough. This is a video, so you can pause it. You can pause the button, you can rewind, and then display. Okay, so I think the code will be still there on the video for you to watch. Okay, so if anything else, no. Thank you very much, respiratory, oncology, cardiothoracic team. Excellent 2 cases. I learned quite a lot. Yeah. And we hope you enjoyed it too as well. So we're going to end the broadcast. We're going to end the broadcast, but remember, the code is valid for maybe another half an hour more. So roughly about 4 o'clock onwards, I don't think you can scan for points anymore. Okay. But if you're watching this, the broadcast has ended. You can still rewind the video to watch everything. But if you want to scan the points, quickly scan, fast forward to the point where the QR code is displayed, and scan for points before it expires. Okay. The code will expire by about 4 p.m. So we wish you good afternoon. Now, one more thing before I end. the next session is next Saturday. Actually, the other grand rounds, which will be presented by, again, the cardiology team, but this will be the March session. So the cardiology team will still be presenting during the first Saturday of every month. So they're back again on the 6th of March at 2 p.m. Saturday afternoon. And the topic is thyroid and the heart. Okay? Masquerader and, sorry, the heartbreaker. So the registration, everything on the same page will be updated later this weekend. Okay, so, and the SJMC coordinator will contact you all for the grand round. So, okay, the points are still there. You can scroll back the video and scan for points, even if you haven't. Okay, all right. So have a good weekend, everybody. Bye bye. We're ending the broadcast now.